Hello, and welcome to another live broadcast with MedStar Health. My name is Karen Single, and I'm joined today by cardiac electrophysiologists, Dr. Zayd Eldadah and Dr. Meininger, and cardiac surgeon, Dr. Shults. Today, we're discussing long-standing persistent AFib. Did you know that September is National Atrial Fibrillation Month? And that's why it's important that we're here with you today to discuss new treatment options. If you didn't know, atrial fibrillation, or AFib for short, is the most common type of arrhythmia. In fact, 1 in 4 adults over the age of 40 will develop AFib in their lifetime. And approximately 45% of those patients, and that's more than 3.5 million in the United States, have long-standing persistent AFib, meaning their AFib has lasted for more than a year and will not go away. So until recently, there were very few treatment options available for this condition. And that's what we're going to talk to you about today. We're going to talk about AFib in general, including what it is and the diagnosis of AFib, as well as these new treatment options. So thank you for joining us today. Give us a like, let us know you're watching, share this broadcast with your friends and family. And if you have any questions for our experts, please ask them in the comments. So before we begin our discussion, I want to welcome our experts and ask that you all introduce yourselves. So we'll start with Dr. Meininger.
Hi, my name is Dr. Meininger. I'm based out of Baltimore Union Memorial Hospital. I'm the director of cardiac electrophysiology, MedStar. I trained at Hopkins, but have been working in Baltimore ever since. I've been with MedStar in particular over the last 15 years. One of my areas of interest is, in particular, managing atrial fibrillation.
Thank you very much. Dr. Eldadah.
Hi, everybody. My name is Zayd Eldadah, and I serve as Director of Cardiac Electrophysiology for the MedStar Health System for Baltimore and Washington. Like Glenn, trained at Johns Hopkins and then joined MedStar Health in 2004 and had the privilege of working in this terrific system ever since then, and working with my terrific colleagues on this program here and so many other experts in multiple disciplines, all focused on improving health in this region and beyond.
Thank you. And Dr. Shults, why don't you introduce yourself?
Hi, good afternoon. My name is Shults. I'm a cardiac surgeon here at MedStar Heart and Vascular Institute. I've been with MedStar for about 8 years, did actually undergrad med school residency here in Georgetown in DC, and then went down to Emory for fellowship training, and then spent some additional time in Europe for some additional training. I've been in practice here for 8 years, and happy to be here today to talk about AFib. This is something that's become a very growing part of my practice, and I've had the privilege of collaborating with both Glenn and Zayd to deliver these kind of newer therapies that I think are, quite frankly, they're an example of how we at MedStar really are collaborative and interdisciplinary, and how we offer solutions to patients' complex problems.
Thank you very much, all of you. We appreciate your time, and let's get into some questions. Let's just start talking about generally, what is atrial fibrillation, or AFib?
Maybe I'll just jump in. So atrial fibrillation is a change in the way the heart beats. The heart is a beautiful organ that from about 10 weeks of gestation, when we're in our mother's womb, starts to actually contract. It's a muscle that has 4 chambers. And just to show you just a quick example, this is what the heart looks like. If you open up the heart and see what it looks like on the inside, it has 2 upper chambers and 2 lower chambers. And the way the heart works is to squeeze in a very rhythmic way, the upper chambers together first, followed by the lower chambers. And that organized choreography of upper and lower chamber contraction is what keeps us alive. It's what's kept our blood circulating from very, very early in our existence. In atrial fibrillation, what happens is the upper chambers, instead of contracting in a normal, organized way, a way that's responsive to our body's needs, slowly when we don't need it, meaning when we're asleep or at rest, and more rapidly when we're engaged in activity or need a faster heart rate, the upper chambers in atrial fibrillation get hijacked by chaotic electricity that results in their not squeezing at all, but rather quivering. very rapidly, very uncontrollably. And the results of that is that the bottom chambers of the heart, which actually expel blood from the heart, the chambers that actually generate the pulse that we feel, that generate the blood flow that goes to our bodies, that contraction sequence becomes erratic, irregular, not normal, not nice and rhythmic, but rather chaotic. Often very rapidly so, in other cases slowly, but always irregularly so. And that's really what atrial fibrillation is in terms of a description. I'll turn it over to Glenn to talk about some of the clinical findings that people have in atrial fibrillation.
So in terms of atrial fibrillation, just to add to what Zayd has commented, there are intrinsic causes and extrinsic causes that can drive or precipitate atrial fibrillation. In particular, it is a rhythm that is exacerbated by things like high blood pressure, obesity, valvular heart disease, obstructive sleep apnea. So these are medical conditions that contribute to stress on the upper chambers of the heart. You can think of atrial fibrillation really as a wear and tear rhythm on the heart, which is why we see age as such a dominant driver. As people get older, we see more atrial fibrillation. In terms of some of the lifestyle components that really play into atrial fibrillation, certainly things like caffeine, alcohol, stress, dehydration, poor sleep patterns, all can be a contributing factor. So when we see atrial fibrillation, we're really kind of looking at what are the aspects of a patient's life that are contributing to these episodes of atrial fibrillation, and what aspects to a patient's life can we help to modify the development of atrial fibrillation. So maybe in terms of the diagnosis, it's many times made by patients who develop symptoms through monitoring, whether that is monitoring with a watch or monitoring with a Holter monitor or other special types of monitors that patients may wear. But often it begins with patients' awareness of the irregularity in their heart rhythm and some abnormality in the way the heart is beating.
So what are some of those symptoms? Would it be something that you feel automatically, or you mentioned monitoring it through some type of other device? Can you talk a little bit more about what someone would feel if they may have AFib or have AFib?
And this is the trick, is that nobody really shares identical symptoms, but we do see some common themes for symptoms. So for the obvious symptoms, some people describe a flipping of a fish in the chest, or irregularity in the heart rhythm, palpitations. But for others, it may be simply discomfort in the neck, or shortness of breath, or swelling, fluid retention, or even chest discomfort or lightheadedness. So, but for many patients, even as many as a third of patients may have no awareness at all. And this is more incidentally found after some of the other symptoms become more progressed.
Okay, thank you very much for that. That was a great explanation of what it is and how it's diagnosed and the symptoms. Does having any type of AFib put someone at higher risk for other health conditions? Dr. Shults, you want to answer that?
Mm-hmm. So AFib, in addition to the symptoms that have been described, the symptoms are significant often. The patient's inability to kind of exercise, just kind of feeling of unsettled and not feeling well. But if you look at patients greater than 65 years of age, and you look at their 5-year survival trajectory, if they have a diagnosis of AFib, it's actually worse in patients with colon cancer or Hodgkin's lymphoma. So it's not a benign condition. And I think that, it's something that should be treated, should be dealt with. And I think part of the reason we're talking about this today is that, there are a lot of new treatment options that are available to treat patients with AFib. I think, coming through medical school, my understanding is if a patient has AFib, treat them with blood thinners and rate control, just kind of try to control their rate, and that's the best you can do. But we've learned that that's not the case, that there are a lot of treatment options for patients with AFib that can effectively get rid of the AFib. If not entirely, then reduce their AFib burden significantly, which has huge implications for not only how they feel, but also how they do over the long term.
Can you talk about those various treatment options?
Yeah, sure. I don't mean to jump ahead of the program here, but
it was perfectly planned.
Yeah, Zayd and Glenn can probably talk more about the catheter ablation, but I think it's important to kind of classify. AFib can be classified into 4 different types. The first is paroxysmal, meaning that you're popping in and out, and no one episode of AFib lasts longer than a week. And then you get into the persistent, which means that you're having the AFib, and when you have AFib, it lasts longer than a week and up to a year. So that's kind of paroxysmal. Then there's persistent, and then there's long-standing persistent, which means that you're in AFib and you can't get out of it. You're in AFib for over a year. And as you can imagine, as you kind of climb up that, and then there's permanent, which means basically that everyone's decided there's nothing we can do to reverse it. You're just going to be stuck in AFib. Mm-hmm. But as you can imagine, as you go up that ladder, it becomes more and more difficult, and the more and more nuance in how you treat these patients. And the treatment is a little more complicated. Glenn and Zayd can talk about paroxysmal. They, in the EP world, they're very effective at treating paroxysmal AFib. Oftentimes, they're treated with medications, cardioversion, blood thinners, and then if that fails, then they're sent to the lab for what's called the pulmonary vein isolation, which is an ablation. But as you kind of climb up that ladder, the effectiveness of a pure just ablation becomes less and less. And then it's, I think, appropriate to start talking about, well, what other options are there? And one of them is the one we're talking about today, which is a hybrid ablation. Hybrid meaning because it's the combination of two specialties, electrophysiology, Dr. Meininger and Dr. Eldadah, and cardiac surgery, myself, and basically trying to tailor a solution in a very minimally invasive way that's more effective and minimally invasive, but to kind of deliver effective therapy for these patients. And that has led to this, the hybrid or convergent procedure, which was recently FDA approved, which is very exciting. And it was a trial kind of randomizing patients 2-to-1 in the convergent arm, which is the hybrid arm, versus catheter ablation alone. And it shows significant advantage for the hybrid approach for these patients in persistent and, in particular, long-standing persistent atrial fibrillation.
Thank you. Yeah, that's very exciting. And I know we have a lot more that we want to talk about with the specific hybrid therapy. But I do want to hear a little bit more. You mentioned medication and cardioversion treatment options and ablation treatment options. Can we talk a little bit more about, can someone explain those options? And then love to talk more about the specific hybrid therapy treatment option that was just recently FDA approved.
Maybe I'll just jump in to say something very simple. So when somebody has a diagnosis of atrial fibrillation, just like Dr. Shults mentioned, regardless of type, whether it's periodic or paroxysmal, episodic, little bursts here and there, every few hours, every few days, but for a fixed period of time, and then spontaneous resolution, or persistent atrial fibrillation, which the episode stays for a week or longer, and something has to be done to either shock the heart out of it, or long-standing AFib that's there much longer than that period of time, a year or more. We have to remember something very important. The first and foremost goal of anything in medicine is always to treat what's most dangerous first, and then deal with the other stuff later. What's most dangerous in atrial fibrillation is the risk of stroke. And so treatment for atrial fibrillation starts first and foremost with stroke protection, protecting patients against the risk of stroke. What we have to remember is that every individual with atrial fibrillation may not always have the same exact risk of stroke. But what we do know is that having atrial fibrillation elevates the risk of stroke compared to not having atrial fibrillation at all. And that risk increase is about 5-fold. So you take any human being, regardless of medical condition, and throw on atrial fibrillation, and suddenly you have a 5-fold increased risk of stroke. And stroke is not a benign problem. As you know, stroke simply means a blood clot that travels to the circulation of the brain, stops blood flow to an area of the brain, and results in injury or death of brain tissue. And that can lead to conditions as catastrophic as death very rapidly, or severe paralysis, severe neurologic defects like lack of the ability to speak or control parts of the body, or potentially a minor defect that could resolve. But it's a problem that we want to prevent as best as we can, and that's our first priority. So stroke protection is our first priority, and that's generally accomplished in one of two ways, either with medical therapy, a drug as simple as an aspirin a day for low-risk people, a blood thinner, such as warfarin historically, and now we have newer agents known as the direct oral anticoagulants, drugs like apixaban or rivaroxaban or dabigatran or edoxaban. Those are drugs that reduce blood clot risk in patients with atrial fibrillation. And there's a newer therapy of an implantable device that occludes an area of the heart that can cause, that's an area of actual hotspot of stroke. So the simple take-home message is if somebody has atrial fibrillation, please speak to your physician about what therapy you're getting to prevent the risk of stroke. Now let's take that priority out of the way. The rest of our conversation is about the atrial fibrillation itself, the arrhythmia itself, which, as Dr. Meininger said before, can be completely imperceptible to patients. There are a proportion of patients, interestingly, who are fully functional, have no idea they have atrial fibrillation at all. Sadly, actually, there's a proportion of those patients whose first diagnosis of atrial fibrillation comes in the emergency room when they present with a stroke. They had no concept that anything was wrong with them because they had no symptoms, but they developed a stroke. So very important to remember that. For those who have atrial fibrillation and are being treated for stroke protection or prevention appropriately, that's the rest of our conversation today at this event, which is what can we do for them? For patients who have atrial fibrillation episodically, we often start with a medication to slow the heart rate in cases of fast heartbeat, and also to suppress the atrial fibrillation itself, a medicine that actually acts as a calming medicine, a chill pill, if you will, for that chaotic, rapid atrial chaos that's the source of the problem. And that can work. It can work reasonably well, but it often doesn't work long term. And that's where we have escalated our ability to deal with this problem. And catheter ablation, which is a procedure that's now a same-day one, in the hospital and out the same day, done through the large vein of the thigh, in which scar tissue is purposefully created in an area of the heart to block the atrial fibrillation signals. That's the next best step, another step that can improve patients' symptoms and quality of life and long-term outcomes for their health. And then when we proceed to the very next step, that's convergent atrial fibrillation, which we want to talk about today. And I'll turn it over to my colleagues to speak a little bit more about convergent, because as Dr. Shults mentioned, it does really represent how medicine can be very rewarding, keeping the patient's best interest as our focus and bringing more than one discipline together in the same room at the same time to offer the best we can for that patient.
And just one add-on before convergent is sort of discussed is, a lot of times we're really centered on that management and treatment of symptoms, but it's not just the symptoms that you're seeing now, but it's also the symptoms that we perceive you to be at risk for in the future. So really a lot of our aims are that combined approach of stroke risk protection and symptom management. And again, a lot of people may be minimally symptomatic early on in episodic atrial fibrillation or even in more persistent atrial fibrillation. But what we want to think is the downstream impact of persistently being out of rhythm, losing the priming function of that. I mean, the heart is a pump, and the pump function of an atrium is to prime the main pumping chamber of the ventricle, which is the one that pumps throughout the rest of the body. So we are trying to help manage those symptoms to protect against some of the long-term consequences of atrial fibrillation.
Maybe I'll interject one thing, because what Dr. Shults and Dr. Meininger have both mentioned is that atrial fibrillation is a progressive condition. It's not just an infection that happens one day, gets treated, and goes away. We have to think of it as a progressive condition. It's actually a change in the atrial tissue, the heart muscle tissue, that's progressive over time. And the number one driver of that is the aging process. And sometimes when I talk to patients, I just come up with simple analogies, like think of dandelions in a yard or in a park or in your garden. They often start here and there, weeds that just come out of nowhere. And it's pretty easy to deal with them when they're few and far between. But if you totally neglect your yard, those weeds start to multiply and multiply, and pretty soon there's no more healthy lawn left. It's all weeds. That mimics the progression of atrial fibrillation. It often starts episodically, comes and goes, then comes and goes and lasts a little longer, because each time the atrial fibrillation is happening, it actually exacerbates some of the underlying degenerative processes in that upper chamber muscle tissue of the heart, such that those chambers stretch, they contort, they become less normal, and that in time gives rise to more atrial fibrillation and more stretching and then more atrial fibrillation. So it's a vicious cycle. What Dr. Meininger was just mentioning is that intervening early, stopping that progression and restoring rhythm to normal earlier can help prevent those downstream structural changes and all the problems that may happen down the road. Those problems, remember, are independent, though. They take a life of their own. They're independent of the stroke risk. The stroke risk problem is over here, has to be managed on its own. Everything else that we're talking about, symptoms, structural problems, preventing downstream consequences, is what we're here to talk about with drugs, catheter ablation, and convergent therapy.
Thank you, Dr. Eldadah. We actually have a question related to that the stroke risk, and also the not knowing that you even have AFib. This question is from one of our viewers, Noreen. She said her husband suffered a life-changing stroke as a result of an undiagnosed AFib. So that happened to her husband. So she's asking, should people get randomly tested for AFib? What would you tell Noreen?
Yeah, I mean, I think that is absolutely a great question. We have much easier ability to monitor patients, but we don't have a routine screening strategy for patients with atrial fibrillation at this point. But certainly people who are at high risk, by high risk meaning have other cardiovascular risk factors, high blood pressure, obesity, sleep apnea. When cardiologists review these patients, often in the back of our mind, we consider overall risk for atrial arrhythmias. But this is the sad truth, is that it is very difficult to have an organized strategy to screen everyone for atrial fibrillation, although monitoring is becoming much more commonplace because of the ability to do it through app-based monitors on your phone, through watch-based monitors, such as Fitbit or Apple Watch. We are seeing many more episodes of atrial arrhythmias that are occurring in the presence of no symptoms. What to do with that information becomes tricky, and there's a lot of effort spent now on trying to not only identify these patients, but in whom do we aggressively pursue treatment strategy.
Sure. Thank you very much for that. I'm going to take a quick pause and just welcome any of our new viewers, and thank you for all the questions and comments that we've received so far. Just a reminder and to share with our new viewers that today we're talking about atrial fibrillation. We're going to switch gears a little bit. We talked about generally what is atrial fibrillation, what are the symptoms, and some treatment options. And we're going to talk about long-standing persistent AFib. And we're here today with cardiac electrophysiologist, Dr. Zayd Eldadah and Dr. Meininger, and cardiac surgeon, Dr. Christian Shults. So if you have any other questions, I know we had a question about the specific hybrid procedure with which Dr. Shults started talking about a little bit earlier when we were talking about treatment options. So let's talk more about that. Tim had interest, and I know we want to share some more information about this new FDA-approved treatment for longstanding AFib. So if we can start just by sharing with our viewers, so we talked a lot about what AFib is and the fact that it's not episodic, it's something that happens over time. Can we talk about the long-standing AFib? Is there more that you'd like to share about the difference between long-standing, and I think we think of that, and correct me if I'm wrong, as having AFib for more than a year. How is that different from just having AFib in general? Dr. Eldadah, did you want to answer that one, or?
Sure. So, again, using that analogy of atrial fibrillation being a progressive process, it starts off episodically here and there, maybe with or without obvious symptoms, but there's changes that are happening inside the heart, and those changes are progressive, much like the dandelions that come up in your garden, the weeds, one here, one there. If treated early, if stopped early, the grass stays uniform and green and nice. If not, the grass can get more pockmarked with more weeds, and if left completely unattended, totally overrun by weeds. The very same process happens. So if the atrial fibrillation is allowed to progress without intervention, there are actually structural changes that get worsened in the heart, such that the upper chambers stretch and become more what we call fibrotic. The actual muscle fibers change and get interspersed with more scar tissue actually within them, and that makes them less functional, less able to contract well, more likely to fibrillate. So the convergent atrial fibrillation procedure is actually one that MedStar, the team at MedStar, introduced to the DC Baltimore area back in 2011. So we're almost celebrating our 10th anniversary of introducing this therapy. Very early on, we used it for those very refractory cases, and it's only until just now that there was a formal FDA label given to this technology for that particular class of patients, patients in whom the atrial fibrillation has gotten so far along, their yard has been so overrun by weeds that the muscle tissue needs more than just a drug to suppress the AFib or just a simple catheter therapy to suppress the AFib. So in convergent atrial fibrillation, there's a convergence. There's a convergence of how we treat the tissue from the inside of the heart and the outside, and a convergence of specialists, the cardiac electrophysiologists using a catheter from the inside, and the cardiac surgeon who uses an apparatus delivered to the outside of the heart directly. And that converging of technology, of specialty and expertise, and of physical location on the tissue has been shown to be an effective way to help blunt that progression of AFib and actually restore normal rhythm and keep people feeling better, improving their symptoms, and stopping that progression of the AFib, halting it or slowing it such that their quality of life can be restored. It's a very rewarding opportunity to be able to do that for patients, because that class of patients in whom the atrial fibrillation has been present for a year or longer and just can't seem to be shaken off is a frustrating situation to deal with for patients, for families, certainly for practitioners, because there's nothing more we want than to restore sinus rhythm to everybody, but it's not always that easy. This opportunity with this technology helps us do that far better than what we were able to do before. And I'll turn it to Chris, who can share.
Yeah. Thanks, Zayd. So I just dovetail off what Zayd has said. And Zayd, I really like that analogy of the dandelions. I'll have to use that. That's fantastic. But I think that, the transition from paroxysmal to persistent, the mechanism of the atrial fibrillation changes. It's no longer kind of triggers that exist in the pulmonary veins. It's, the entire morphology of the atrial fibrillation changes. So it's now more about kind of rotors and drivers that are circulating through the entire left atrium. And so the mechanism of treatment is also different. It's about kind of disrupting those channels, if you will, that kind of circulate through the heart, so that if an AFib trigger kicks in, that it can't persist and you can't go into this persistent rhythm. And that's why this ablation of the posterior wall component, kind of eliminating those channels for this kind of persistent atrial fibrillation to live and to persist, is so important. I will also just say that Zayd and his team, and under his leadership, they kind of recognized this opportunity, this new technology, and they were kind of had the foresight to kind of adopt this even 2 years before I got here. I just kind of joined and benefited from their foresight and kind of took it, kind of made it a lot more reproducible and streamlined. But they had the foresight to they were early adopter in this kind of this technology. So we've been doing it for 10 years, and we've done close to 300 cases, which is, looking across the country, we're probably in the top 5 in terms of volume, certainly the number 1 in this larger DC metropolitan region. And we've got a lot of experience with it. There's a lot of, like anything, there's a lot of nuance with any new procedure that, and the tips, the tricks, the expertise is gained over time. And that's something that we've done here.
Thank you for that. Is this procedure available at certain hospitals, or where is this procedure offered? I know we mentioned MedStar Health. Is that specifically at MedStar Washington Hospital Center, and where else could it be found?
Yeah, so it's offered at both, the procedures at MedStar Washington Hospital Center, but also MedStar Union Memorial, where Glenn is. It's offered at both campuses.
Wonderful, thank you. We have a lot of interest in this procedure and some questions from our audience, so I will ask those now, and then I have some more questions for you as well. A lot of excitement around this. This question is from Brent. He says, I was treated for AFib about 15 years ago, numerous cardioversions, 2 ablations, and medications. So he's gone through some different options there that you talked about earlier. Nothing has worked to end his AFib. He's now 63 with persistent AFib, and wondering if there's anything that can be done for him. Would he be a good candidate for hybrid convergent therapy, perhaps?
So he'd certainly be a good candidate to review and look over everything. And absolutely, that's the group that I think tends to fit well into hybrid ablation, particularly patients that are still symptomatic, despite all these efforts to try and restore and maintain normal rhythm. There are some patients in whom it may be challenging, even with the options of having hybrid ablation, either because the left atrium is significantly enlarged, that leads us to feel that this alone may not be the ultimate solution, but there are many strategies that we choose. And again, even if we take a patient that is in chronic persistent atrial fibrillation, we consider using drug therapy combined with something like convergent or hybrid ablation. And if we can limit those episodes of atrial fibrillation and really minimize those, I think it can have a major impact on quality of life. And I think we all now, working with this technology, have seen many patients who've been told in the past that they have really no options available, that have done very well long-term and able to maintain sinus rhythm after completing this type of ablation.
Thank you, Dr.
I'll
Meininger.
just comment. Sorry, can I make one more comment?
Oh, you're good. Yeah.
So I think that, the question that he raises is, this is, as Glenn mentioned, this is the perfect patient that we can often see. And I think that, the point is, to Glenn's point, that patients like this really should come in to get evaluated, because there's a lot of options that they may not be aware of, and that perhaps, frankly, other places may not be aware of. I think that, the hybrid ablation is just one example. It's really kind of a comprehensive treatment strategy for atrial fibrillation. There's a lot to talk about.
Thank you very much for that. Thank you, Brent. We'll get you the information that you need so you can see our experts and hopefully get to better health with this treatment option. We have another question. We actually have interest from both Mary and Kelly. Thank you for your questions, both of you. They wanted to know about the Wolf mini-maze procedure. They're asking whether what's the difference between that and the new the hybrid procedure.
Yeah, sure. I'm happy.
What the Wolf mini-maze procedure is, because I don't think we talked about that earlier. I think that would be helpful for other viewers who don't know what that is.
Yeah, I'm happy to talk about that. So, a lot of the literature that that has been developed and kind of the treatment and what is a strategy? How can you effectively limit atrial fibrillation? A lot of that is based on what's called the Cox-Maze operation, and that is for patients who are having heart surgery already. It's a biatrial maze, and maze because it's Cox maze. James Cox, who's the one who kind of came up with the procedure, and maze because you're literally creating a maze on the heart that limits how energy can move through the heart. So it makes it it forces the energy to move through the heart in a desired pathway. So you're basically creating a maze. And for patients who need heart surgery, they need an aortic valve, they need a bypass, they need a mitral valve repair, and they have persistent AFib. That's a wonderful solution, and the effectiveness of that procedure is fantastic. the group that's more challenging is and kind of what we're talking about today is the patient population who they don't have an indication for heart surgery, but they have this persistent or longstanding persistent atrial fibrillation, and what can be done for them. And the convergent procedure, although it's not a full biatrial maze, the foundations of it, we're trying to kind of as best we can through very, very minimally invasive means, trying to approach or approximate that lesion set. The Wolf mini maze is it's effectively a biatrial maze, but that's done through a thoracotomy, a small incision between the ribs on the right side, where you go in and you do a full biatrial maze. Now, it does require going on pump, so you're on the heart-lung machine. Your heart has to be stopped. We have to open up chambers. So, as we talk about kind of treatments, there's a stepwise approach that each step is a little more invasive, but it's also more effective. And the hybrid ablation is kind of right in this middle. It's the next step. It's not as invasive. You don't have to go on the heart-lung machine. You don't have to stop the heart. It's small incisions, one just below the breastbone, and 3 small incisions between the ribs. That again doesn't require heart-lung machine, doesn't require arresting the heart. So it's less invasive, and I think in some respects I would consider the Cox mini maze or the minimally invasive full biatrial maze could be theoretically the next step on that pathway. It's more invasive, but more effective. But that's also something we offer for patients, and I think it could be theoretically a logical next step. If they had the convergent down the road 1 or 2 years, they failed, they could come in. That's another option, and that's just another example of a lot of options that can be discussed. And these are all options that we offer, and it's really just finding what's best for the patient, because some patients would say, hey, just do whatever you need to do to fix my AFib. That's all I care about. In which case, they're a great candidate for that. Others, including a lot of referring providers, say, no, I don't want. Let's hold off on going. We don't want to drop the nuclear bomb yet. Let's try something else before that. So, it's these conversations, but it's important to know that there's all things we offer, and it's about kind of catering it to the patient, what the patient wants, and what we think will work, kind of, and balancing that risk benefit.
Thank you very much. That's a good segue to the next question. Is we're thinking about and talking with our physicians about treatment options for the hybrid convergent therapy treatment option. How long is a typical hospital stay after that procedure? So if you're thinking about do anything you need to do for my AFib, that might be a consideration that you're thinking about and talking with your physician about. Can you talk about what's the typical stay look like, the risk factors, the safety of the procedure? I don't know who wants to take
So I'm happy to take that as well. So the patient, they'll be in the hospital for 2 to 3 days. We do make a small incision and come into the pericardium and also into the pleural space. So they come out with a couple very small drains that are left in for a day or two, just to make sure that there's not fluid accumulating. Those drains are taken out, and then they're sent home at day 2 or 3. From my perspective, on a scale of 1 to 10, 10 being some of the crazier things we're doing in cardiac surgery, maximally invasive, this is like a 1 to 2, and I think patients generally tolerate it very well. I think I tell them it takes about 1 to 2 weeks to kind of fully recover, and they're up and walking the first day after surgery, and then short hospital stay, they go home, and at 2 weeks they're effectively back to normal.
That's great. Thank you. Does this procedure cure their longstanding AFib, or what type of outcome do you expect after this procedure takes place?
Yeah, so from the literature, from the Converge study, which was the randomized control prospective trial, we saw that at 1 year, patients with persistent atrial fibrillation, or persistent and longstanding persistent, the effectiveness was 70%. So 70% of those patients at 1 year should expect to be in sinus rhythm.
So, and I think just to piggyback on that, often with AFib, I think we get stuck on the term cure, because, this is really, there's a lot of things that have led to the development of atrial fibrillation, really a lifetime of changes in the atrium. And so what we're really trying to do is not necessarily eliminate every episode of atrial fibrillation, but certainly our goal is to keep that burden of atrial fibrillation as close to less than 1% that we can. And many times in these longstanding persistent atrial fibrillation patients, our target isn't that zero AFib, but it's rather if we can limit it to a rare episode on occasion, and even if we have to combine the strategy with the use of medication, that's what we anticipate will provide the most success for patients long term, is really minimizing the burden of atrial fibrillation or atrial arrhythmia.
Sure. Yeah, that makes sense.
The following, that atrial fibrillation, as Dr. Meininger actually said at the beginning of his presentation, presents uniquely in every unique individual. There's no stereotyped or single screenplay for how atrial fibrillation presents in terms of symptoms, severity, health consequences. And similarly, treatment has to also be unique for every individual. So that's why I think one of our take-home messages is, regardless of the type of atrial fibrillation or your presentation of atrial fibrillation, whether you were just diagnosed, have been struggling with it for a long time, come to a provider whom you trust, somebody who can look at you with a multidisciplinary team and tailor therapy to be just right for you, to bring the best of capability, experience, the evidence-based work that we all try to bring to our patients every day for that patient's best interest, so that we can tailor an approach that's just right for the atrial fibrillation that we're encountering, patient by patient by patient. There's no one-size-fits-all therapy for AFib. It has to be a tailored, a thoughtful approach.
Thank you, Dr. Eldadah. What about after procedures? What would patients expect after this procedure in particular, or any of the procedures? Feel free to speak to any of them. What would they have to do in terms of follow-ups or medications? Is there specific medications or blood thinners that they need to take? Could we address that as we think about kind of full circle? What is the, not just what happens after the outcomes, but what would a patient expect to need to do after this treatment is completed?
Yeah, I'm happy to take that. So, patients should expect, for at least for the first 3 months, their medication regimen will largely be the same as before the procedure in terms of the antiarrhythmic drugs and the anticoagulation. I'll typically see them at 2 to 3 weeks, and we'll do an echo, just an ultrasound, just to look at their heart and make sure there's no fluid around the heart, and just to check on them to see how they're doing. And really, there's frankly, no restrictions after 2 weeks. They can kind of get back to their normal life. And then after that, they'll go back to their electrophysiologist, their cardiologist, and then we'll talk about, maybe there is potential to kind of wean some of these medications. And I don't know if Zayd or Glenn would like to talk about that.
Yeah, I mean, typically we are continuing, as Christian mentioned, the medications both for rate control or rhythm stabilization following the ablation procedure. Typically, anticoagulation is an independent piece, as Zayd had mentioned before. Anticoagulation, if they're indicated prior, which many of these persistent atrial fibrillation patients are, we're typically continuing it post-ablation. We're generally using it for at minimum 3 months. If they're a low-risk patient in whom we may not need long-term anticoagulation, that's when we're contemplating coming off of it. But yes, most patients, usually it's the 2 week of kind of taking it easy, no heavy lifting, no heavy exertion, no exercise, but after the 2 weeks, back to full activity and getting back into your life activities.
Thank you very much. I have one more question to ask you from our audience, and a kudos. We'll start with the kudos that came in for Dr. Shults from Chris. He said, I just had surgery in June. Dr. Shults put a clamp in the top of my heart. It has completely stopped any AFib. Everything is good. I was able to get off 2 meds because of this. Thank you, Dr. Shults. So wanted to share that kudos with you all. So, one size doesn't fit all there. He had a particular procedure and he talked about his follow-up. So thank you for sharing that, Chris. And then I have one question, and then we will wrap up our broadcast. This one is from Florence. She says, I have AFib that increased with chemo. I had a pacemaker, but I'm still having AFib. Is that normal? What would we say to Florence? Who wants to take that one?
Also, I guess again, I think it highlights the theme that no two people experience atrial fibrillation the same way. There's maybe a concept in the community that a pacemaker, a device, can fix all heart rhythm disorders because it will set the pace of the heart. That's actually not the case. A pacemaker really only does one thing. It allows the heart to beat faster than a preset minimum rate. So if a heart rate or a heartbeat is slower than it should be, a pacemaker is used to elevate that heart rate. A pacemaker can be present in somebody with atrial fibrillation or somebody without atrial fibrillation. In the presence of atrial fibrillation, the upper chambers of the heart, again, quiver very rapidly, 300, 400, 500, 600 quivers a minute, and try their best to transmit all that energy, all that impulse to the bottom chambers of the heart. If the bottom chambers of the heart respond in a rapid way, and a patient has a pacemaker, that pacemaker will just sit back and watch the chaos ensue and not do anything because there's nothing for the pacemaker to do. The heart's beating faster than that preset rate. If, on the other hand, the bottom chambers of the heart are beating slower than that preset rate, they'll be irregular, but slowly so, then the pacemaker can kick in and stimulate the heart. But that doesn't stop the chaos that's going on in the upper chambers of the heart. So if I understand the question correctly, is why is my atrial fibrillation continuing despite my having a pacemaker? It's because a pacemaker doesn't fix atrial fibrillation. Fixing AFib involves addressing the tissue that is fibrillating, the upper chambers of the heart. And that's addressed by the therapies we talked about. Drugs that specifically calm that tissue down, catheter ablation done alone, generally for patients who have milder or episodic atrial fibrillation, in which we create scar tissue in the upper chambers to block the AFib. And for more progressed cases, those that are what we call long-standing, persistent cases, we do the procedure that Dr. Shults and the electrophysiologists converge on, which is the convergent AFib hybrid procedure. So those things happen independent of whether a pacemaker is present or not.
Thank you very much for that. Before we wrap up, I do want to just remind everybody where they're able to get the new FDA approved treatment option that we talked about, the hybrid convergent therapy. Is that therapy available at most hospitals, or is it just a select few? I know we mentioned MedStar Washington Hospital Center and MedStar Union Memorial. Is it available anywhere else?
It's available in selected centers that have experience where surgeons and electrophysiologists work together. In the MedStar health system, the Baltimore metropolitan area, we've concentrated that procedure and that expertise at just 2 hospitals, MedStar Washington Hospital Center in the DC region, MedStar Union Memorial Hospital in Baltimore. There are other hospitals in our local area that have adopted the therapy after its introduction here about 10 years ago as well. And there are other hospitals around the country, but it's not a procedure that's, for instance, offered in community hospitals all over the place or in smaller centers because it's very resource consumptive. You have to have a dedicated cardiac surgical team, a dedicated electrophysiology team, and that resource presence is generally available at larger, more tertiary care centers.
Thank you very much. And we'll make sure to share that information in the comments to make sure that everyone today has access to learn more and to request an appointment. We're going to complete our questions for today. We did have some wonderful questions that came through in comments. So just want to thank our viewers again for that. Any questions that we did not get to today, we will certainly follow up with that after the broadcast. But with that, I would love to just finish up by asking this question to each of you. What is one, a key takeaway that our viewers should walk away with today after watching this broadcast? Let's start with Dr. Meininger.
So, I think one of the keys is just awareness of symptoms, know that that there are resources available, and certainly through the MedStar health system, we're happy to see you. Happy to re-review your case if you've been told that it's that there are no options available to you, because often what we find is that there are approaches that can be available that may not have been thought about or looked at. And a lot of it just depends on, who you see and sort of what experience they have in managing the condition.
Thank you very much. Dr. Shults, what takeaway do you have for our viewers?
I think Glenn hit the nail on the head. Just that there's options available. So please, if it's AFib something you're dealing with, we're happy to see you here at MedStar, you'd benefit obviously from this really highly collaborative team. It's been a pleasure, quite frankly, personally, to work with both Glenn and Zayd, and to offer this new therapy and a very comprehensive strategy for AFib.
Thank you. Dr. Eldadah, what would you like to say to our viewers before we wrap up?
I'd just like to say that atrial fibrillation is associated with the aging process. We're all aging, whether we're 5 years old or 90 years old. And so it becomes more likely that we develop it over the course of time. It's not something that we need to be afraid of or ashamed of, but it's a condition that we need to address. And if it's present, or we think it might be present, we need to take it seriously, because there are consequences of AFib that are not helpful, that can be dangerous, and that can also degrade our quality of life. And thankfully, now we have technologies and expertise available to both save life and improve the quality of life. So if you're somebody who might have atrial fibrillation, might be fighting with it, dealing with it, experiencing it, concerned about it, see your physician, talk about it. We do have lots of options, lots of expertise in the region, and physicians who really want to do their very best for you, because one of the greatest satisfactions that we get is when somebody has a problem that's affecting them, putting them either at risk or degrading their quality of life, and having that risk lifted, having that quality of life improved, and getting postcards from patients traveling again, doing the things that they like to do. That's what we're here to do, improve the quality of life and the quantity of life.
Great. Thank you all very much. Those are wonderful takeaways. Thanks again for your time. Thanks for educating our viewers and taking care of our patients. We really appreciate it. We hope our viewers learned something today. I know I did. So thank you so much for watching. You can continue to comment, share this broadcast with your friends and family who hadn't had a chance to watch live. It'll be available on our Facebook page and on YouTube as a replay. So we encourage you to watch it again, to continue to share and educate your friends and family about this new FDA-approved treatment option, as well as really general AFib treatment options as well. So take care. Thank you so much for joining, and we'll see you next time.
Take care.
Thanks.